Chapter 41, Assessment of the Musculoskeletal System. The priority concept of this chapter is mobility. The interrelated concept for this chapter is sensory perception and pain. The anatomy and physiology of the musculoskeletal system. Bones classified by shape. Long bones such as femur, which is weight bearing. Short bones such as the phalanges, they're limited weight bearings. They're also classified by the structure. Cortical, compact, strong outer layer. Cancellous, spongy. Medulla contains the red and yellow marrow. The red marrow, hematopoiesis, where the red blood cell production is done. The yellow marrow, fat storage. This area has a risk for fat embolism syndrome, FES. Bone cells such as osteoblasts build bone. Osteoclasts break down bone. The Haversian system, the blood supply and nutrient delivery system. The lacunae houses osteocytes. The framework and weight support. Movement through muscle attachment, protection, organs, blood cell production, the red bone marrow, mineral storage, calcium and phosphate. The hormonal regulations. Parathyroid hormone, PTH, increases serum calcium bone reabsorption and decreases renal excretion. Calcitonin, made by the thyroid, right? It decreases the serum calcium by inhibiting bone resorption. Vitamin D enhances calcium and phosphorus absorption. Estrogens stimulate osteoblasts. Postmenopause equal bone loss in women. Androgens increase bone mass. Thyroxine, which is T4, increases protein synthesis, bone growth. Insulin and growth hormone build and maintain healthy bone tissue. Ethnic considerations. Ethnic groups. Black, increased bone density equals a decrease in osteoporosis. Amish, increased incidence of dwarfism. Chinese, shorter, smaller bones, increases osteoporosis. Egyptians, shorter than blacks and whites. Filipinos and Vietnamese, short, average height is about 5 feet. Irish, taller, broader, but decreased density than blacks. Joints, how they function, why they function. Our joints allows flexibility and movement. Types of joints. Synarthroidal, immovable, which is the skull. It doesn't move as the brain enlarges. Amphiarthroidal, slightly movable, such as the pelvis. Diarthroidal, synovial, freely movable. The elbow and knee. Lined with synovium, lubrication, shock absorption, commonly affected in arthritis. Then you have the bucce, which prevents friction, can develop bursitis. Then we move on to the synovial joints. The ball and socket, example shoulder or hip. The movement is multidirectional. Then you have the hinge, which is the elbow, flexion and extension. Then you have the condylar, which is CONDYLAR, is a complex hinge, which is the knee. It has flexion and extension and then slight rotation. Then we'll move on to the musculoskeletal system. The skeletal muscle is striated and voluntarily controlled by the CNS and the PNS. Motor end plate, junction between the nerve and the muscle. Fascia calculi, FASCICULI, bundle of muscle fibers. Fascia surrounds muscles, contains blood, lymph, and nerves. The functions is movement, support posture, and generate heat. Disuse atrophy. This happens when the muscles aren't used. It decreases muscle mass due to aging or immobility. Supporting structures. Tendons, muscle to bone. Ligaments, bone to bone. Clinical implications: immobility risk, pressure ulcers, pneumonia, DVT, constipation. With our aging, we'll see increased bone reabsorption, decreased muscle fibers. With your assessment, pay close attention to joint function, bone pain, mobility, and cultural considerations. Musculoskeletal changes associated with aging are common age-related physiological changes are decreased bone density, osteopenia, which leads to osteoporosis. Consequences is increased fracture risk. Kyphosis, widened gait, decreased balance, increased fall risk. Cartilage degeneration, joint pain, osteoarthritis is a risk. Decreased range of motion, decreases in ADLs and the patient's independence. Muscle atrophy, decreased strength. Consequences, fatigue, mobility issues. Slow movement, frustration increases, which increases the patient's fall risk. Increased bony promises. It increases the risk for skin breakdown. Our nursing interventions: physiological change, decreased bone density. You want to teach fall prevention strategies, encourage weight-bearing exercises to prevent fractures, which slows bone loss. Increase bone prominence. You want to reposition these patients frequently or by policy of the facility. Most places is every 2 hours you turn in the patient. You're making sure you're using cushions or pillows, something to get the pressure off those bony areas. Prevent pressure ulcers is our number one priority. Kyphosis, gait changes. Teach body mechanics. Supportive seating is needed. Assess for assistive devices. Promote safety and balance. Cartilage degeneration, osteoarthritis. So with this, we want to use moist heat, warm shower or warm compress. This enhances the blood flow and joint mobility. Decrease range of motion. Assess ADLs. Consider assistive devices. This maintains function and independence. Muscle atrophy. Teach the patient isometric or isotonic exercises. Strengthens muscles, prevents decline. Slow movement. Allow time. Avoid rushing these patients. When we don't rush the patients, we reduce their frustration and we reduce their fall risk. So we want to prevent falls. So we let them take their time. Health promotion and disease prevention. Supplementation. Encourage calcium and vitamin D intake. Exercise, weight bearing such as walking, strength training. Fall prevention, safe home environment. Make sure the walkway is not cluttered. Make sure there's no loose rugs on the floor. Make sure that everything is safe in a house for a patient. So we need to educate the patient and the family on this. The use of assistive devices. If they have one, encourage them to use it, whether it's a cane or walker, whatever. And if they're getting up walking by themselves, make sure that they have on footwear that's non-slip, like non-slip soles or shoes. Make sure they have on full shoes, not just house shoes that they slide into, because some older people, when they put house shoes on, they still tend to trip over their shoes. So we have to be mindful of that. If they had surgery, we need to make sure that they're putting on shoes that tie up and not walking in shoes that they just sliding their feet in, and that's because that's a safety issue. Also, educate on body mechanics, supportive chairs, posture age, and we want to make sure that these patients are avoiding risky behaviors such as smoking, chewing tobacco, vapes, whatever else you want to call something that's smoking, nicotine related, because they decrease bone healing, they increase the fracture risk. We want to make sure that they are not drinking excessive alcohol. It decreases the nutrition absorption of vitamin D and calcium. Um, we want them to stay away from high impact sports, such as excessive running. It increases joint and bone injury. We want to make sure that they're not riding a motorcycle unsafely or a bike unsafely, uh, especially young men. It increases trauma and fractures. Teaching tip for older adults: reinforce patient-centered care by tailoring prevention plans based on functional status, cultural background, living environment, and caregiver support. This is very important. Um, Patient history, recognizing clues. We want to go to the assessment, so we're going to look at patient history. Key questions to ask: past injuries. Have they had any fractures, any sprains, any sports trauma, even if it's decades old? Do they have any chronic conditions, osteoarthritis, diabetes, osteoporosis, or gout? Pain management, including cannabis or over-the-counter supplements like glucosamine or chondroitin, chondroitin. If they self-medicating, so we need to make sure we ask those questions. ADL limitations. Do they have issues with bathing themselves, taking themselves to the bathroom, getting themselves dressed, or transferring from a bed to a chair or from a chair to a bed? Do they use any assistive devices such as walkers, canes, or wheelchairs? What medications are they on or supplement histories, and have they taken in the past? Have they taken steroids, vitamin D, or calcium, or are they currently taking them? Are they allergic to anything, especially dairy, which will decrease calcium intake if they are? Um, we need to also realize that culturally there are some changes, there are some issues. Hispanic, American Indians, and Alaskan Native groups show higher disability rates. Risk is linked to social determinants of health, poverty, education, employment disparities. This is a big deal, especially when it comes to taking care of one's health. So just be mindful of it when you're doing your health assessment on your patient. Nutritional history. Assess calcium and vitamin D intake. Are they taking supplements? Assess protein and vitamin C for tissue repair. How much protein? This is where we start asking questions like, what is a normal meal for you a day? What are you taking in? Significance in weight loss and gain. Have they lost any weight that they weren't trying to lose, or had they gained weight that they wasn't trying to gain? We need to know. And we need to know what's going on with that. Risk factors: lactose intolerance, which leads to decreased calcium; eating disorders, which leads to decreased bone density; obesity leads to joint stress and decreased mobility. Um, we need to watch that with our patients. We say our patients aren't moving. Sometimes they haven't moved in so long because of being obese that now when they do move, those areas hurt, those joints hurt. It's hard for them to get their muscles moving because they've been sitting still for so long. Then we want to look at their family history, genetic risk. Ask about osteoporosis. Ask about gout. And gout is hereditary. It's a purine metabolism issue. And we can get it passed down from our families. So we have to ask those questions. Current health problems, chief complaints. Are they in pain or do they have weakness? Gather as much data on either or, such as onset. When did it start? Duration. How long does it last? What makes it worse? What improves it? Is it heat, rest, or movement? Does any of that make it worse or better? Pain characteristics. Is it sharp, dull, burning, aching, stabbing, throbbing, radiating? Where is it located? Does it go anywhere else? Weakness. Where is it located at? Is it proximal? Myopathy, muscle problems? Is it distal? Neuropathy, nerve problem? Physical assessment. Physical assessment. General inspection. We're going to look at the inspection, palpation, activity, and passive range of motion during this physical assessment. So first we're going to start with the posture. Curvatures, lordosis, inward lumbar spine is curved. Kyphosis, hunch thoracic, nickname hunchback, right? Then we have scoliosis. The lateral spine is curved. With all three of these curvatures, the patient will walk totally different than a person whose spine is straight. So we have to be pay real close attention to our patients. We have to look at their gait, observe how they balance is. Is it steady? Do they have to hold on to something when they walk? Do they lean when they walk? What's their stride like? Do they shuffle their feet? Do they try to walk with wide legs? We have to look at all of this. Do they walk with a limp or do they have a deformity? If any of these are present, we have to refer the patient to a rehab therapy if needed. Then we go and we look at their extremities. Assess both sides for size, symmetry, tenderness, deformity, range of motions. Is there any limitations? And what are they? We have to make sure that everything that we're finding in their assessment, that we're writing it down and we're charting it. We're looking at their hands and their fingers and how they function. Critical in the musculoskeletal exams, we need to check. So as we get to the hand and fingers, we have to check the metacarpal phalangeal joint of the fingers, which is the knuckle right when we go to make a fist, right? Then we have to check the proximal interphalangeal joint, which is right in the middle of our finger. And then we have to check the distal interphalangeal joint. And we ask the patients to make a fist, touch each finger to their thumb, right? And we make them do it on both hands. Then we move on to muscle strength. We assess the tone, the buck of the muscle. Do they have any resistance? Example, ask your patient to raise arms against your hand. Optional, use strength grading scale 0 to 5 for quantification. Okay, so this is stuff that we learned back in physical assessment. Then we got our clinical red flags. Finding, pain with movement. Potential concern, fracture or joint injury. Finding, bone pain. Potential concern, lesions, tumor, or infection. Finding, proximal weakness. Potential concern, muscle disease. Finding, distal weakness and sensory changes. Potential concern, neuropathy. Finding, gait instability. Potential concern, fall risk. Finding, joint deformity. Potential concern, advanced arthritis or trauma. A lot of the stuff that I'm going over in these that I'm putting on this slide is noted in your books. It's either in the tables or the boxes. So if you hear me saying something that you may have not read or you may not remember, then you need to just go on your book and you need to go to these table and boxes and find it. Summary for practice and teaching. When assessing musculoskeletal functions, gather a thorough health history, assess lifestyle and nutritional factors, and conduct a systemic physical assessment. Always correlate findings with functional ability and potential for injury or fall. Use interprofessional referrals such as PT and OT when limitations or abnormalities are noted. Mobility and functional assessment, collaborative approach. As nurses, we have to work with PT and OT to assess needs for assistive devices, such as canes and walkers if the patient doesn't already have one. We also have to evaluate safety during transfers and ambulation. ADLs and function, observe ability to perform activities like dressing and bathing. Note any pain, deformity, or sensory impairment which can limit the function. Range of motion, ROM. Evaluate affected areas unless the patient is fully independent. Range of motion assessment involves inspection, palpation, and movement testing. So don't say you assess their range of motion if you didn't look at it, if you didn't palpate the area, and if you didn't move it. Skin integrity. Check for redness, hyperpigmentation, lesions, warmth, which may indicate inflammation or pressure injuries. You also have to pay close attention to certain areas, like the bottom of the heel. I just learned a new trick. So the wound care nurse told me to get a compact mirror. You know, it's hard to look at people's feet when they laying in the bed, right? So you get a compact mirror, which is two-sided. You place that compact mirror up under the person's heel, and you could see the whole heel without trying to, bend over and flex and do all this extra stuff. Joint specific notes. Hip. Pain may radiate to knee, back. Hard to palpate. Yes. Knee. Easy to inspect when flexed. Look for effusion, deformities. Ankles and feet. Often overlooked. Palpate for swelling, tenderness, and deformities. Our patients are getting younger, and what used to be, as we call them, older people diseases are not just older people diseases anymore. We have a lot of people in their 40s and 50s that's dealing with a lot of joint and musculoskeletal issues. So we have to be an advocate for them, and we have to do our due diligence when we're doing our assessments. Neurovascular assessment. Nurse safety, priority action. Assess injured extremity first, then compare bilaterally. Includes pulse, and if you can't feel the pulse, then we may need to do a Doppler if we can't palpate it. Use a Doppler. So pulse, sensation, movement, color, temperature, capillary refill, and pain. So we assess the injured side first, and then we compare it to the opposite joint or limb. So if we do the right first, then we compare it to the left, right? Then we go to our psychosocial assessment. Assess for anxiety, depression, chronic pain, loss of body image, such as amputation. Identify any support systems that are needed and or the patient has, and what type of coping mechanisms are the patient using, if they are using any. Then we refer them, consider spiritual or psychological counseling. So we have to refer them out. And some places have, everybody's policy is different. But if you don't know how to get your referrals out, we can always ask a case manager or a social worker or even the doctor, what's the next step to get this patient these needs that they need. Diagnostic assessment, laboratory test. This is table 41.2. All the labs are noted there: calcium, phosphorus, ALP, CKMM, LDH, AST, ALD. So calcium, normal range 9.0 to 10.5 milligrams per deciliter. Significance of abnormal findings: increased bone mets, Paget's disease, a decrease in calcium, osteoporosis, or osteomalacia. Phosphorus 3.0 to 4.5 milligrams per deciliter. Significance of abnormal findings: increased bone healing, tumors, decrease shows osteomalacia. ALP 30 to 120 units per liter. Increase leads to bone cancer, osteomalacia, Paget's disease. CKMM in males 55 to 170, in females 30 to 135 units per liter. Increased levels: trauma, muscular dystrophy. LDH 100 to 190 units per liter. When it's increased, necrosis, muscular dystrophy. AST 0 to 35 units per liter. Increased muscle trauma, dystrophy. ALD 3.0 to 8.2 units per deciliter. Increased polymyositis, dystrophy. Imaging assessments. X-rays, first line. This is the first thing we do before we do anything else. It shows bone density, alignment, and joint space. CT, best for vertebrae and joints. Asks about iodine contrast allergy. MRI, superior for soft tissue, may use contrast. MRA is an MRI plus contrast into joints, useful for rotator cuff injuries. Ultrasound, soft tissues, joint injuries, osteomyelitis. Bone scan, which is a DEXA scan. They inject radioactive isotopes, done 4 to 6 hours later, may repeat at 24 to 72 hours, used for tumors, osteomyelitis, osteoporosis, and then we gonna push fluids after to clear out the isotope, the radioactive isotope. So if your patient has to have a bone biopsy, or you getting a patient ready for a bone biopsy, confirm A bone biopsy confirms infection or cancer. Methods: needle, which is closed, or open, which is incisional. For post-op, we have to watch for bleeding and infection signs. Those are major. For a muscle biopsy, for muscular dystrophy or inflammation, polymyositis, myositis, same day procedure, same procedure. You can do a needle, which is closed, or you can do an open, which is incisional. Same care as a bone biopsy. So we have to watch for bleeding and signs of infection. Arthroscopy, the purpose is diagnose or repair a joint issue, most likely knee or shoulder. They are not friendly. They are very painful after you have it. Patient prep must be able to move the joint, not perform on affected joints. Teach range of motion exercises pre-op if needed. You have to get a signed informed consent is required. Procedure is local, general, epidural anesthesia. Small incisions for scope insertion. And sometimes, depending on how bad or the procedure, how bad the joint issue is, they may do a nerve block. Post-op care, nursing safety, monitor neurovascular status of the affected limb, pulses, color, warmth, capillary refill, movement, sensation. Mild pain equals acetaminophen. Surgery may require opiates. Ice and elevation. Ice for 24 hours, elevate 12 to 24 hours. With knees and shoulders, they have those machines where you can put ice and water in the machine and put it on there. And when I say that thing is amazing, it's amazing. It helps decrease the inflammation. So when a patient goes through, say, a rotator cuff repair, and they give them that, you have to put ice on it. You have to, because something foreign just went in there and the doctor just repaired that area, but it feels inflamed for a few days. So the ice will help with the inflammation and everything else. And then you elevate it so that it won't swell. Complication warning signs: swelling, severe pain, signs of infection, thrombophlebitis, right? So we need to just pay real close attention to all of that. So I hope you enjoy this first recording of chapter 41. Take your time, listen to it, then go back and listen to it and write your notes from it, or add to your notes that you already have. I'm going to get it posted, and I will talk to you on the next one.